All right, we will get started. Today's talk is about cancer screening and just really screening in general. You know, I thought some of this came about for a couple of reasons. I think it's an interesting thing, but you know, we as doctors, and then even more so amongst the regular lay people, you know, overestimate the value of screening and underestimate the harm. You know, we talked yesterday about getting PET scans and finding papillary thyroid cancer. You know, any test we order, obviously we don't intend to cause harm, but sometimes we don't appreciate the potential to cause harm. And so just this is sort of just food for thought. It's not that I'm against cancer screening. I'm not. I'm for cancer screening in general. It's just we need to understand the data behind it. You know, part of this was when all this pandemic started, everybody started, you know, talking about sensitivity and specificity, and you know, people just don't understand it. So we'll go through that a little bit. And then the other reason that I kind of became interested in this is when I turned 40, I went to get my whatever. I hadn't seen a PCM in forever, but I was like, I need to get my cholesterol checked. And I went there and I saw the provider, and they're like, yeah, we'll check your cholesterol, we'll check your PSA, we'll do all this. And I'm like, whoa, I don't want my PSA checked. And they gave me a hard sell, like, you don't want to know if you have prostate cancer? And I'm like, that's not what that test does. And anyway, but I mean, like, you know, if I hadn't been pretty forceful and pushing back, I would have gotten it. Okay, so important definitions. Sensitivity, so that's true positives out of all the positive, out of over true positives plus the false negatives. Okay, so how likely is it, if you have the disease, is it to pick that up? Specificity, true negatives divided by true negatives plus false positives. So if you don't have the disease, how likely, is that right? True negatives? Yeah, how likely is that to be accurate? Or if the test is positive, well, that's probably pretty good. Yeah, anyway, that's it. This is why it gets confusing. I have to, like, every time think about this. The positive predictive value, basically, if you have a positive test, what's the likelihood that's accurate? Negative predictive value, the inverse of that. So if you have a negative test, how likely is that to be accurate? Accuracy is true positive and true negatives over, regardless of the test, if it's positive or negative, how likely is it to be true? And then the prevalence is the proportion of the population who have a disease, whereas the incidence is the same thing as prevalence, but over a time, or the risk of developing it over a given time. Typically that's given in a year, but it can be other time. Okay, so hopefully y'all didn't read that, but I'm getting a medical student. So what is a test that, if you want to make a screening test, what are the conditions that make for a good screening test?
That it's specific towards the disease that you're trying to screen for.
Okay, so that your test has good specificity. Okay, I think that's true. What else? But let's talk about less about the test and first about what disease processes should we develop tests to screen for. Does that make sense? Like, do we need to screen everybody for plantar warts? You know what I mean? Should we make a campaign to do that? What do you think? What's that?
No to plantar warts.
Good, good.
But a disease with
yeah, it needs to be a serious problem. There's no point in screening for something that's not a big deal. There is this thing called disease mongering, where basically a drug company has a drug. They need an indication for it, so they put out a campaign about how everybody's got low T or restless leg syndrome. And then all of a sudden the diagnoses of that, you know, we need to screen for these problems, but really, you know, are people better off when now that their, you know, leg that's moving in the bed is treated? I don't know. But, you know, we don't, so people will make arguments to screen for things that aren't a problem, but they all have secondary gain. But in general, yes, it should be a big problem. You know, we don't want to screen for things that aren't a big deal. What else?
Something where we could actually treat it.
Correct. Yeah, we don't screen for ALS or things that, you know, glioblastoma, where we can't really do much about it. No point in doing that. And then any other thoughts on it? What else? What are one other condition that needs to be met? Anybody? not necessarily preventable. That you could do that if it was if there was like a precancerous or in general, there's a latent stage. There is a window where you catching it early makes a difference. If pneumonia probably fits all those criteria, but catching it, can't catch it early. You get it when you get it, and so there's no point in screening for it. Okay, good. So in general, as we talk about, how screening tests perform, in general, you have, this is for cancer specifically, but it would hold true for other things. You get one of 4 possible outcomes when you perform a screening test. So if it's cancer, one is you detect a cancer that would have been found later and treated with a cure regardless. So this is sort of the papillary thyroid cancer argument, like why we don't screen for it is because if you wait a little while until they're symptomatic, they really have an incredibly high cure rate for the most part. It's not, it's a little more nuanced, but if you pick a cancer where, the cure rate, like for example, squamous cell skin cancer, it's almost always cured when it's found. We don't need to go with some big screening campaign for it. Another is you find a cancer that cannot be cured even with early detection. And that's like why pancreatic cancer screening trials haven't really worked, or glioblastoma ones, because, regardless of when you find it, they're probably going to die. And so finding it early isn't going to make a huge difference. The other outcome that's underappreciated, and this again goes to the papillary cancer, and we'll talk a little bit more about this, but is that you detect a cancer that would never have been found. So it was a cancer that they would have lived and died with and never known they'd had, but now you have it and you don't know that that's the case, and so you have to treat it. And then finally, is the whole reason we do screening tests is that you potentially detect cancer that you found it early and it made a difference. Okay, so just keep in mind that those are the 4 possible outcomes. And so this gets, into another argument that basically, this is the turtles, rabbits, and birds argument, that you've got a barn, your screening test is a fence you're going to put up, and you want to keep all of the rabbits in. Okay, but what proportion of the cancers, there's some cancers are turtles, they're in the barn and they're never going to leave, they're just too slow. Other ones are birds, you're building the fence and they're gone. You detect them, but it didn't matter, they're going to die from it anyway. And you want to keep the rabbits in. So anyway, it's what's the proportion when you're doing the test, what's the proportion of the cancers that are rabbits? And that's the hard part to know. In other ways, bad cancers are bad, good cancers are good. And a corollary to that is, big cancers are bad, small cancers are good. There's some truth to all those sayings, but it's just kind of, you got to think about it when you perform when these tests, that these things happen. So what's the problem with screening tests, or what are some of the potential problems? So lead time bias is one. So this really goes into how do you determine how a test is performing. In general, almost every trial that looks at how a screening test, cancer test performs, looks at cancer-specific mortality, right? Because if you want to look at overall mortality, people die from a lot of things, and if you pick the most common killer in women, or that's still lung cancer, but if you like the second most, if you pick breast cancer and say, well, lots of women get breast cancer, lots of women die from it, still the vast minority of women die from breast cancer. Usually they die from other things. And so your trial has to get substantially bigger, cost more. It really becomes, the number needed to treat or number needed to follow is prohibitive. So let's look at cancer-specific mortality. The problem with that is you start to run into these biases, which are difficult to control for. So lead time bias is you can't follow necessarily people forever. And so you generally follow them for some fixed period of time. Well, if you detect a cancer early, like these 2 graphs basically represent the exact same cancer, right? But this one is detected through screening, and this one is just detected at when it becomes symptomatic, and they would have become symptomatic at the same time. But at the end of the day, because you detected it earlier, it's a lead time bias. And so it's perceived that, women who get screening mammograms and are diagnosed with breast cancer, are 25% more likely to be alive at 5 years after their breast cancer diagnosis than women who found them on exam. oh, great, we should get mammograms. But in reality, nothing has changed. And again, I'm not saying that's true. That's just an example. I shouldn't say breast cancer. I should say cancer X. And then you have length time bias. And so this just has to do with how cancers perform. So this really goes back to the turtles, rabbits, and birds argument. So if you have a cancer here and where you perform a screening test at this location, all of the blue lines were cancers that were detected by that screening test. All of the black lines were cancers that were not detected by that screening test. And then the arrows are people who are going on to live, and the X's are people who go on to die, right? Well, bad cancers, the birds, are less likely to get detected because basically they come and become symptomatic and present or kill people more quickly than slow cancers. Slow cancers that are just hanging out, not doing anything, are just more likely to get detected. You know, they're sitting there, they're less likely to become symptomatic. And so at the end of the day, you know, you're more likely to find the slower cancers. And I mean, that's why, you know, when we get a CT scan and find an incidental mass, you know, usually those are more amenable to resection than the patient you get a CT scan and they've got cancer everywhere. Because, you know, maybe you're getting lucky and catching it right in that window, but maybe it's been that way. And I mean, you know, you can talk to Dr. Nichols. And I mean, there's tons of times where we find an incidental mass, they come to see us, it's, you know, some sort of malignancy. And then you look back at their scan from 2, 3, 5 years ago, and it was missed. It was there. And sometimes it's gotten bigger, but sometimes it hasn't, you know. I mean, I treated a gist like that. It was a big 5-centimeter gist in the antrum, and it was clearly there in the same size 5 years prior. And it's kind of like, well, this is a high risk gist. I mean, it ended up being kind of high risk, but anyway, like, you know, in your heart, you're like, well, I got to take this out, but you kind of almost don't know if it's the right thing. But anyway, but at the end of the day, if you look at the statistics for this, the ones that are found by screening do better. Makes sense, right? And so it allows you to overestimate, or causes you to overestimate, the value of your screening test. This is just another sort of way to do that. If you had screening at these time points, you have basically different tumor trajectories. And so the slope roughly represents, like, you know, how aggressive it is. But and then these regions are, this was before the tumor's microscopic, it's localized to one organ, regional spread, metastatic spread. And so when you're going to find it, or ideally, is when it's localized to one organ. You're not going to find it microscopically. And so you have basically different tumors, ones that will never become apparent, ones that become apparent, but probably never would have become an issue in their lifetime. It wouldn't have left that organ. And then this is the one basically where you could potentially make a difference. Whereas some tumors you'll never catch because they're just too aggressive. Okay. Other problems with trials that look at screening tests are there's a big selection bias in those. And so that's basically the people who participate in screening trials are not representative necessarily of the general population. You know, people who participate in trials in general are more motivated, have more, tend to be healthier, take care of themselves because they're interested in this kind of stuff, and then often have more resources. And then the sensitivity, specificity, and prevalence are really important if you want to do a screening test. And that's where really, when the whole COVID screening, when these antibody tests came out, I had a publication about it, but this is kind of where it came about, is because, like, the prevalence, people don't understand that the prevalence is really, really important. Like, you can have the best test ever, but if you're testing for something that's not the best, you can have a really good test, but if the prevalence is low, the test may not perform well. And we'll talk about that. And then the other part is this: the risk and cost of screening are important. That's something that, you know, we in the United States don't talk as much about as other countries. But, you know, if you make a test, let's say low dose CT scans for lung cancer, or, you know, MRIs for breast cancer, those cost real money. And, you know, I know it's not, the patient's not paying for it, the insurance company is, but overall that inflates the cost of healthcare. I mean, at the end of the day, that's money that could go to a school lunch somewhere, or to, you know, somebody due to early childhood intervention. It's hard to measure those things against each other, but you know, cost is something. Okay. So all cancer tests. Yeah, it's Pam, are you on mute?
Oh, sorry.
Okay, so let's just, as for an example, talk about, this is just to show you again that the prevalence matters. So this is Clifton's disease. If I have a test that has 99% sensitivity and specificity, that seems pretty good, right? Everybody would like that test. And then the prevalence of this disease is in 1 in 10 people. We got a test for Clifton's disease is rapidly fatal. We got to test everybody right now. And so we test 100,000 people. With those numbers, we would get a true positive rate of 9,900 and a false negative rate of 100. So basically 100 people who had the disease were missed with my test. And then the true negatives, most people don't have it, are 89,100, and basically false positives are 900. Okay, so 900 people were diagnosed with Clifton's disease. Hopefully the treatment's not bad. I don't know, but 900 people were falsely diagnosed. So basically that makes a positive predictive value. If you have a positive test, there's a 91% chance you have the disease, but the negative predictive value is pretty good. 99.8% chance if you got a negative test, you're negative, right? Okay, so let's say we increase the prevalence to 1 in 1,000, or decrease the prevalence to 1 in 1,000, right? Do the same thing, we run through those things. Now you have fewer positives because there's fewer people with it, and more false positives, a few more false positives. Really, the false positives haven't gone up a ton, but the true positives have gone way down. Now all of a sudden your positive predictive value is 9%. Your negative predictive value is better because it's just less prevalent. But if you're positive, still the vast majority of people who have a positive test don't have it. And this is where what it was happening with COVID, where we had these, tests with an 85% specificity, and they were testing everybody in the community. And then, we didn't really know 100%, but the thought was that the community prevalence was like in the 5% range. Well, if you do the math on that, if you get a positive test for your antibodies, the vast majority of the time, that's a false positive. Anyway, so, and if you make it even more extreme, I mean, that those numbers just get worse, where now you have, it's almost like a worthless test because, the negative predictive value gets better. But anyway, so, and that's if we drop, that's actually the same numbers as before, but we dropped the specificity from 99% to 80%. Now, all of a sudden, your positive predictive value is really, really bad. So can a test like that be worthwhile? Sometimes, like when we test for HIV, this is how it's done. The sensitivity is high. The specificity is still pretty high, but the prevalence is low. And so if we test all these people, if you get a positive test, chances are it's not positive. And this is what happens when you get your blood drawn. They do an ELISA HIV test, but the negative predictive value is very good. However, if you have a positive, it leads to a reflex Western blot that is incredibly specific. And so that's basically why it's a good screening test. If you have, it's because of the combination of the two. But if we only had ELISA, it wouldn't be that good because you're going to start antiretrovirals if that's the only test you've got. You know what I mean? Okay. All right. So let's talk about, let's get into cancer some more. There's been a couple trials that have looked at screening. So why don't we screen for ovarian cancer? We're going to talk about, basically, this is a good example. So this is the PLCO trial where they enrolled for different types of cancer, but looked at screening. The reason that the rationale behind this is that there's a 5-year survival rate of 94% when localized. However, it drops it's very poor when it's spread. And then, ovarian cancer, not the most common cancer, but it's something that's seen for sure. And so how this worked was a large number of women were screened with CA-125 and then transvaginal ultrasound for 6 years and then followed for 13 years, okay? In that screening group, they diagnosed 212 ovarian cancers and there were 118 deaths from ovarian cancer, okay? In the other arm, there were 176 ovarian cancers diagnosed, so fewer, and then 100 deaths in that arm. So, I mean, what's your takeaway from this? Maybe a benefit, They're similar. I mean, yeah, I mean, so I think you could argue that best case scenario, there's like an 18% reduction, something like that. But, and that seems like a lot, but when you look at the number needed to treat, the absolute value and the denominator, it's really high. But, you know, we've done more for less. So, oh yeah, you're right. That's a good point. Yeah. No, so no benefit to that. I may have got, I want to make sure I got that right. Say that again. Well, there's no statistical difference between those two. Yeah, so I mean, you're right. It may be just the normal variation, but I thought there were, I may mix this up, but regardless, the kind of the big takeaway, the reason this trial, there was no statistical difference regardless. And then this is the real issue. In the screening arm, there were 3,285 false positives, basically patients who went on to get some other test because of a finding on their transvaginal ultrasound or the CA-125. So, you know, if you break it down, that's about 10% of women. And then that led to 1,000 oophorectomies. So that's about, you know, 3% of the study arm ended up getting their ovaries removed. And then, you know, as you can see, the vast majority of these were not for ovarian cancer. They were more likely for something incidental, you know, that they were concerned about. And then 15% had at least one major complication from that surgery. So you ended up with 19 and a half surgeries for every screen detected cancer. And then there was no difference at all in late stage ovarian cancer, which is the ones that killed people. Okay. So let's just briefly review some screening recommendations. Actually, this has changed to 45. Sorry, I should have updated that. But in general, for colon cancer screening, there's multiple options, and those include colonoscopy, sigmoidoscopy, and then FIT testing. The value of colonoscopy in particular is that it not only detects cancers early, but it can prevent them. There is some difference in the preventive task force or in the different recommendations, but they've actually they're now aligning on 45. So we're going to run out of time, and I don't want to keep people here long, so I'm going to blow through this. But in general, let's just go through these tests, the advantages and disadvantages. For FIT testing or fecal whole blood testing, it's easy and cheap to do. It's got very little risk. And as far as the risk to the individual, but it does require a colonoscopy if it's positive. It has a low sensitivity for polyps. And so therefore, and then generally the compliance with it is pretty poor. People, you know, you tell them to do it for 5 years, they do it for 2 years, and then they forget. So that's that. Flexible sigmoidoscopy, less risky than a colonoscopy. It doesn't require a prep. And if you ask anybody who gets colonoscopy, usually the prep is the worst part. The disadvantage only finds left-sided polyps. That's because for probably a variety of reasons, screening scopes have only been shown to decrease mortality for left-sided cancers. And then if you have polyps, you still have to get a full colonoscopy. CT colonography, non-invasive. It's good for detecting polyps that are greater than a centimeter. There's very little risk with it. But you still have to do the prep. And then any abnormal results require a colonoscopy. There's some radiation risk, although at that age group, it's probably not a big deal. Colonoscopy looks at the entire colon. It can be both preventive as well as diagnostic, but it does require prep and sedation and has a risk of perforation. Any questions on that? It's pretty standard stuff. I know you've heard all that. Okay. Cervical cancer. This is just something that, you know, like if you're involved in cancer, I know we don't treat cervical cancer, but just as you're aware, since it's a screening talk, the recommendations are at age 25 that you get HPV testing every 5 years. This is American Cancer Society's recommendations, or co-testing with cytology and HPV testing every 5 years until your age of 50, as long as you've never had high-grade intraepithelial neoplasia and diagnosed in the past. You stop screening at 65, and that's pretty effective. I don't know what the rules are if you've had a Gardasil. Is there no screening recommendation? You guys probably know. You still do it? seems unnecessary, but all right. Okay. So breast cancer recommendations. So most probably don't remember this, but the U.S. Preventive Task Force, I was probably 5, maybe 10 years ago. I can't remember, but they recommended against screening for the age 40 to 50 for like 5 days because like the world imploded. Like they recommended that based on the data, and then like every woman who had breast cancer, and I shouldn't say that, that's not fair. Every advocacy group, all the societies all just were up in arms, and so they walked it back, and their recommendations were basically like talk to your doctor. But so their recommendation is for that age 50 to 74, you should get biennial mammograms, so every other year. But there again is some difference now in that the American Cancer Society recommends starting at 40 and going every year as long as the woman's healthy. One thing that's interesting has changed is we no longer recommend practicing self-breast exams. Do we know why that is? You guys? It's actually less. It's not that, because we still say practice breast awareness is the term, but it's all because, one, they've never been shown to do anything, but the harm in them is that it causes guilt. So women will come in. I mean, we hear this every time you see a breast cancer patient. Like, I didn't do a breast exam last month. I forgot to, and now I have this, and so my kids are going to be motherless. You know what I mean? It's like it's basically we were trying to guilt people into doing something that, or not guilt, causing guilt, because it was putting it on the patient to do something that had never really been shown to be beneficial. Anyway, all right. So we'll talk a little bit about breast cancer for the rest of the time, just because I think it's interesting, because we all of us overestimate the value of mammograms, and we'll talk a little bit of why. So this is the best case scenario. There's a bunch of trials. They all look at breast cancer specific mortality, but in the best case scenario, mammograms decrease breast cancer mortality in the 50 to 74 age group by about 17%. That's taking the trial that was well done, the best done, performed. And that was out of all of them that have been done, that's the one that showed the most benefit. No, I think that's absolute. Yeah, but that's the best case scenario. So what does that mean? I mean, it means that 83% of women who, in the best case scenario, no, I'm sorry. Yeah, it's not 17% of women obviously aren't dying of breast cancer. It's that. Yeah, sorry. Yeah, it's relative risk. Sorry, not absolute. Yeah. Anyway, right. So 83% of women who develop breast cancer and we're going to die from breast cancer, the mammogram didn't change that outcome one bit. In the 40-year-old group, that benefit is smaller. So it's there. In that case, it decreases the mortality by maybe 3%. And the reason for that is the incidence is so much lower. And then the other reason that the U.S. Preventive Task Force recommended against that at one point was because the harm, and we'll talk about that, is higher in that group as well, because there's just more false positives. The mammograms can miss 20% of breast cancers, so that's one thing. And so the reason that matters is some women will, because we overestimate the value of mammograms, we can lead to false reassurance. Some women will have a palpable mass. They'll get a mammogram, it says it's normal, or their clinician says, well, mammogram is normal, and then they ignore the cancer that would have otherwise been treated. And then as many as 30% of breast cancers are overdiagnosed. And so we'll go through a little bit of that data, but those are kind of the issues with mammograms. So false positives, most women who have a mammogram will get a call back in a 10-year period. And so the false positives for mammograms depends on depends on the study and what you call a false positive. Some people say it's when you get a biopsy. Some people say it's when you get called back. the truth is, if you talk to women when they get a mammogram and they get called back, we need to get another view, many women will automatically assume the worst. And certainly when they get a biopsy, a lot of women are convinced they have cancer, and until they get those biopsy results back. And there's a 3-4 week period in this where they are waiting and worrying about it. So that's one of the harms. And so 7 to 9% will receive a biopsy recommendation. And if you look, the false positive rate for the first examination, it gets worse, or it's worse when you're younger. Is that right? I haven't looked at this in a while. No, it looks like it peaks around 50. I apologize. Anyway, that's the, okay. So, but breast cancer mortality has decreased, right? And so it's hard to argue, or some will argue that, look, breast cancer mortality started decreasing in the mid 80s. We started screening, basically right before that. So clearly that's sort of proof that mammograms work. But the problem is the treatment has also changed quite a bit, and that may, in the end, have a lot to do with it. And so there's a guy, Gilbert Welsh, who really kind of made this his mission to look at this. And so he has a bunch of publications. He's the one who published that Korean database too. But basically, if you look at, the data, this period from the mid 80s to the 90s was when we had widespread introduction of screening mammograms. And we saw a 30% increase in breast cancer. That makes sense. It made sense, in that period that we were finding more cancers early. Good, we found them. But over time, you'd expect a decrease in breast cancer. And there has been some decrease lately, but by and large, and that may have to do with other things as far as like risk reduction therapy, people stopped, or really probably has more to do with after the, what was the study, the nurses study? What's that? Oh, because this is, if you expected a decrease, it's because you're assuming that every breast cancer, if you assume that every breast cancer that people get is going to become apparent at some point, then catching them early will eventually lead to a decrease, because you just caught a bunch of them that were sitting around out there, and then, but they would have showed up in 5 years. And so in 5 years, you're going to have fewer. Does that make sense? So yeah, I should have clarified that. This decrease may have to do with basically women taking fewer hormonal therapy after the Nurses Initiative study came out and showed that hormonal therapy, a lot of women were taking that just because. Maybe. I mean, that would be a big lift to say where prophylactic mastectomies are preventing that many cancers. Okay, but yeah, but at the same time, we're becoming more obese, so maybe the prevalence of cancer has just gone up, So to look at that, he started breaking down the publicly available data. A lot of this is from cancer databases from California, but basically shows that we are diagnosing more early stage cancers, which is good. I mean, that's what mammograms are for, right? But the corresponding decrease in late stage cancers isn't happening. And so, are these? It's harder to argue. Maybe this group would have gone up, and we're just making the difference there. But maybe we're just catching basically the turtles. You know what I mean? And so if you break it down more, again, the incidence of sub-centimeter cancers and in situ cancers before we screened was really, really low. Makes sense. How would you find them if you weren't screening for them, right? They're too small to feel, or if they did feel it, people would be like, it's nothing. And so the incidence of small cancers increased substantially, whereas the increase in T2 and higher cancers really has remained pretty flat. Again, maybe they were destined to increase, but maybe not. Maybe we're just basically finding, this is the whole overdiagnosis argument, that we're finding cancers that, and then so this is, they even break it down by now cancer specific mortality. And basically it's improved across the board when you look at the case fatality rate by these T stages. And that may have to do with, in larger cancers, we have better treatments. In this earlier period, the chemo was different. We didn't have HER2 directed therapy. We do a lot of things a lot differently now, and that's reflected in decreased mortality. But in these ones, it really probably has to do with more of overdiagnosis and a lead time bias. So basically, if you had a 1 centimeter cancer in 1980, it was either palpably visible or maybe it presented with metastatic disease. It was just a really bad cancer, because otherwise, how would you find it? And so you're likely to have more of a higher mortality than if you have a 1 centimeter cancer in 2020, where it was found on mammogram, because we find so many of those, and so many of those that we find incidentally do so well. So basically, it's unclear how much benefit that these mammograms are causing in general, and certainly relative to the harm. Now, it's hard to measure the harm of worry from waiting for biopsy results versus potentially dying. But clearly, the risk of dying if you don't get the mammogram, or the benefit of the mammogram in preventing deaths, is largely overestimated. Okay. Anybody have any questions about that? Now, I know all this data, and when I said there's no way I would recommend my wife get a mammogram when she turned 40, and when she turned 40, I said, don't get a mammogram. And then I saw a woman who was like 35 with breast cancer like a month later, and I was like, go get a mammogram. And and then she got a mammogram, and then I was like, I shouldn't have had her get the mammogram, but you can't unring the bell, you know what I mean? That's the problem, is there's a big emotional part of this. I mean, you can meet lots of women with the world's least risky breast cancer who are convinced that the mammogram saved their life. Then again, you can meet lots of women with the world's least risky breast cancer who showed up 10 years later with metastatic disease. You know what I mean? It's like, there's not absolutes in this, and maybe you did save that life. It's hard to know. So, and that's where it's tricky. Is it's very gratifying to get an image and find a cancer, treat the cancer, they do well. It all feels right. It's harder to not look. And anyway, all right. So let's talk about prostate cancer real quick, just because this was, again, what sort of started my interest in this. There's been 2 large trials that have looked at this, one in Europe, one in the United States. The one in the United States had no impact. They all did PSA for 5 years and then followed people for 10 years, as well as digital rectal exam in both arms. And one showed no effect on mortality. The European study showed a small decrease in mortality. So they found about a 1 death per 1,000 persons screened in the European trial. So let's assume that's the case. So for every death that was prevented, there were 100 to 120 false positives. And this is in men who were 50 years old or older, 50 to 70 years old. 55 to 69, sorry. But you lead to 100, for every 1 death, there's 100 to 120 false positives that lead to a biopsy. And a third of those men get prostatitis and symptoms from it. And then there are 110 diagnoses of prostate cancer. And then keep in mind, this is before watchful waiting. So almost all these patients got either radiation or surgery. And so again, for every death you prevented, you had 50 complications from treatment, including, and this is where I think if most guys, you tell them this data, like for every time we prevent your death, you're 29 times more likely to have erectile dysfunction. That's probably enough. But urinary incontinence 18, 2 would have an MI from their surgery, a DVT or PE in 1, and then there were deaths from the treatment, but they obviously that's included in the death, that even though there was deaths from the treatment, that's factored into their survival benefit. But that's really why screening went away. And in the people who still advocate for screening are urologists. And, maybe that's because they make money from it, but maybe I'd like to think it's more because they see patients who have prostate cancer, who die from prostate cancer, who were found on screening. And it's hard for us to see yeah. And it's the same for me with breast cancer. I mean, I remember the 35-year-old who got a mammogram for whatever reason and had it, it's hard for us because we don't see the vast majority of the harm that is caused by these tests. And then again, so this is the Korean thyroid cancer epidemic stuff. So this was that same guy, Gilbert Welsh. I know we talked about this yesterday, but just to reiterate, there was a screening campaign for cancer in Korea. It did not include thyroid ultrasounds, but for whatever reason, the family practice or primary care groups got in on that. Part of it was how the Korean health system started reimbursing for that. And so they started doing these ultrasounds in clinic, and they were done very ubiquitously. And apparently Korean people follow up with their primary care doctors a lot. But in any case, the incidence of papillary thyroid cancer specifically decreased from around 4 in 100,000 to 70 in 100,000. So like it was like a 15-fold increase. Yeah. The other thing that was crazy, that is crazy, is almost every single patient in this arm got a total thyroidectomy, because that's how the Koreans did it. And this is why they were doing, for a while in we were talking about robotic transaxillary thyroidectomies, and that was all coming out of Korea, basically because they were just, doing it all the time. Like, and apparently it's considered very disfiguring scar for Korean women. But in any case, as you can see, the thyroid cancer mortality, it made a big difference. I mean, it's like hard to detect. It's like impossible, didn't make a difference. So they have gone away from that, fortunately. And anyway, but that's again just sort of the if you just apply a screening test without thinking about it or studying it first, this is the potential risk with it. All right, any questions about that? That's the end of the presentation. Any questions?